Hello, everyone. Um, it's a pleasure to be here to talk about oral health in age-friendly health system. We start with, let me just get my clicker going. Okay, excuse me for that couple of minutes of pause. I need to start this with a couple housekeeping items. The opinion expressed in this presentation are those of the speaker, which is me, and not necessarily those of UT School of Dentistry at Houston. This presentation was made possible by a grant number KO1HP33459 from Health Resources and Services Administration, also known as HRSA. It is an operating division of the U.S. Department of Health and Human Services. So HRSA has offered us this grant and has done greatly for oral health within an age-friendly health system. Also, the opinion expressed in this course should not be construed as an advice to care for a specific patient. Lastly, neither I nor member of my immediate family have any financial relationship with commercial entities that may be relevant to this presentation. With that, let's get to our objectives. The objectives that I put it in 3 objectives, but it's basically 2 if we want to talk about it in that format. It is just how to integrate oral health within a 4Ms, because currently it's not integrated. But the oral health, as we all know, is a big part of overall health. And the fact is that at the end of these presentations, you're going to know that as a non-oral health providers, how do you see or how do you recognize abnormalities in the mouth or in overall oral health? The first poll, I just have this question that I had to ask you all. Do you think oral health education is sufficiently taught in all health professional disciplines? Do you feel you can just look in the mouth as you're doing your baseline assessment? Do you think you can lift up the tongue and look at underneath of a tongue, or look at the gums and look at the teeth? And even if people do not have any teeth, do you look at how their gums look, or if there is any anything that's abnormal? Any abnormality means lesions, means redness, means too much plaque, it means soreness. Anything and anything that you can find in a mouth that looks unusual. And believe me, looking at all these pictures that I've put in, we don't have to be dentists to see something is wrong here. And that's all it's about. How to recognize abnormalities. How do we define oral health? Back in 2016, there was a definition, but by Dr. Michael Glick and his colleagues, that they put it in kind of 3 different tiers. And these tiers, it kind of covered everything, is a multifaceted, included abilities to speak, smile, smell, taste, touch, chew, swallow, convey. If you really look at this whole thing, you can see that every single of those things it's named is a part of a healthcare. If somebody cannot chew, somebody cannot swallow, the lack of taste, lack of smell, muscle expressions that causes this smile. So all these that in a way is a definition of oral health. It definitely is not separated or divided or aside from overall health. So looking at this whole thing, I just added the RX to it, which is in by our definition is medication. However, let me get my laser point here. However, when you look at these three here, even though we are trying to put it in a 4 components, is not exactly what our 4Ms talk about. So what it means in its perfection form. In its perfection form, the 4Ms becomes the main structure, which is what matters most: medication, mentation, and mobility. Bringing this oral health in, put it in this structure, or take this structure and put it in oral health. By the end of this presentation, you'll see how relevant and how related this can be. So let's start with what matters most. What matters most happens to be the umbrella arcing over the other three, meaning medication, mentation, and mobility is not going to take us to the final stage, which is the clinical outcome, without what matters most. And why is that? Let's say I, as a dentist, make these beautiful teeth for somebody, and in my eyes, they look beautiful. They're white as snow. They're straight and square, and they're perfect. Of course, I don't make teeth like that. But if patient looks at me and I said, I don't like this, they look like chiclets. So I didn't meet the criteria of the 4Ms here. What patient wants, I shouldn't say patient, what individual required and their expectation is actually what makes the clinical outcomes be desirable and proper. The one thing you have to keep in mind is what matters most is not something we ask initially and just follow that as a roadmap. That doesn't work that way, because you have to, that might change from visit to visit, time to time, every couple of months, especially if you're seeing somebody every 3 months, 4 months, even once a year. And why is that? Because what matters to people at the given time is based on the conditions and circumstances at the given time. Let's say at some point, your individual that you're meeting in your office, the main thing is that she or he wants to be able to smile, or want to go out, have a better social life, or is just starting dating, or whatever else that can be. In about 3 months, they come back to see you. Sadly, they had a stroke, and they have some kind, now there are more medications involved, now there is mobility involved, that there is the whole what matters most at that, in this circumstance and at this time, it definitely is very different from what you talked about 3 months ago. So checking in every visit, what matters most, that makes the roadmap to the success. For example, I have this patient, his name is George. George is a 82 year, now how old was, I even didn't put it in here. George at the time was 96, a 96-year-old man. He's homebound. He stays in his house, and he is actually cared for by his wife and a caregiver, because the wife is also older than she can actually handle George the way his needs are. So they have a caregiver. George happened to have an abscess in the gum as a result of he had this long bridge here. Something happened probably underneath, maybe a cavity or something on the root surfaces. So the teeth underneath deteriorate, start this big access here in the mouth, and externally, when I got the call and I went in as an emergency, this is how I found him. His face is swollen, red, warm to touch. I even noticed as a result of the swelling, even the one part of a nostril on the nose was even moved. So George is in a lot of pain, even though he's not expressing, he's not able to express. He is in a lot of pain. He is not communicable, so he cannot tell me what matters to him most. I needed to know that George needs to be off the pain. George needs to be back to functions of eating. And George, that used to be a man that would just look at you and smile, and I need to get that face back. So what matters most is sometimes you can ask, sometimes you just have to know by realizing the first thing that can jump at you that making this individual non-functional in that area. So let's talk about another case I had. How about Nancy? This is Nancy. Nancy was in a rehab, a nursing home for the rehab right after a bad stroke. So Nancy, you saw this picture earlier. I had to use this case only because, as you can see, if you see this tooth is longer than the rest of them, it's out of place, it's out of space. And when I touched it, and you can touch it too, it's when you're doing assessment, doesn't mean exam, doesn't mean diagnosis, is just assessment. Assessment, if you touch this tooth, the tooth is going to move. So the assessment says tooth is mobile. We don't have to call it the tooth number, the front tooth, the back tooth, top tooth, bottom tooth. Whatever it is, it needs to be noted as a baseline assessment to come in. And if there is this unusual redness, of course, in some areas you can actually see a little bit of blood. All these are things that do not need a dentist to be there to see. These are the assessments that any health professional can be and should be able to assess as we assess the patient initially to bring him into the system, and know if we see something odd or something abnormal, where to go. So that's all it's about, bringing oral health into the forams and into the age-friendly health system. And once you start paying attention to this, you will actually see that more than you can imagine of elderly, especially the ones with more chronic sicknesses, with more medications, with any more cognitive decline, they have more and more of a oral health issues. So with that, we are moving to medication. Medication is actually what brings, has the most impact on oral health. If I go back and showed you the very first picture I showed you, look in the mouth, there was one picture of just the tongue, that how dry the tongue was. The dryness, 90% has to do with different medications, maybe less, 85 or 80%. I say 85, but because some of it is also ageism, aging as we age. Even though if we are lucky enough up with those 1% or 1.5% that healthier elderly, the function of body overall changes by in age. The function glands reduce their productivity, saliva decreases, the whole organs. But as we get age, even the healthy aging, it doesn't mean with no change. However, those who have medications, especially medications of different class, I'll show you in a next slide that how important it is if we don't know every drug by name and what they do, but we have to know what class of medications will do as far as impacting oral health, and how many of those classes of medications majority of elderly take. And here are the classes of medications that I'm talking about. Most elderly deal with allergies more than younger people because their whole immunity is weaker. When you look at the class of antihistamine, antispasmodics, which they use for IBS issues, constipation usually is routine, unfortunately, and that even caused by a lot of medications. Medications can literally modify functions of a body on top of ageism. Antidepressants, when I go to nursing homes, they are my most, they're the cohort of patients that I see nowadays, as of, I want to say, within the past 10 years. I don't work in a nice dental office with the equipment, with everything in place, and patients who come in on their appointments. I don't have those. I go to see the patients that have not seen anybody, any dentist, anyone in years. Some of them have been in facilities for years. Some of them, like George, are homebound for years. And a lot of them, even if they do have mouth problem, oral health pain, they're not able to express. They work the heavy duty, beautiful cosmetic dental work that they had done 30 years ago, and they require maintenance to keep them proper, is no longer there. So you're looking at depression, muscle relaxant. If you look at all those class of drugs, opioid, blood pressure medications, pain medications, all these come together. If you look at the conditions, they are all the conditions that majority of elderly deal with, at least one or two or three. Some of them 5, 6, or 7. But look at the oral health impact of these medications. If you look at it, most of them cause dry mouth. Majority of them cause, and dryness is the one that causes cavities, causes gum disease. If they are wearing dentures, which you have to note, by the way, if they are wearing dentures, we get to that. I'll tell you why. Those removable teeth, they usually cause oral lesions, ulcers, candidiasis. I mean, you name it. With elderly that are not, their mouth is not looked at, they suffer in silence. So it is very important to be able to bring oral health in our age-friendly health system. That's one example of this lady. She had a long bridge here. As you can see, the other side is still intact. But as a result of, and again, she has Alzheimer's, and as a result of her sickness for years and years, her mouth, because of her medications, was dry. When they called me, she hadn't seen any dentist, and no one, of course, the mouth wasn't x-rays or even examined or even assessed. The difference, by the way, between examination and assessment is with examination, it comes diagnosis, and you need x-rays, and you need to look at everything all together. With assessment, you just look and see what doesn't look normal. That's it. That's the difference between examination and assessment. So we are looking at this this woman that suddenly the whole bridge comes out because every tooth underneath was decayed. That's not a process that can happen overnight. That's years and years and years of decay moving. And at the time she was checked into to this facility, I'm sure the dental box was checked okay. And who checked it, who saw it, what they were looking for, we don't know. And in this case, this actually is this man has is going through cancer treatment, and as a result, he has a lot of cervical caries, and that usually is typical of cancer treatment because the dryness is a lot. And that's where usually the plaque sits. The plaque sits in between the teeth at the gum line. And right at the site of accumulation of a plaque, that's where caries sit. So when you have patients that you know is going through chemo, it's okay to say, oh, by the way, make sure you see, or if they are traveling, if they can't, they have to see their dentist every 3 months, or if they don't want to do that, oh, I don't have insurance, or I can't pay for it, which is a huge part of the access to care, access to oral care. The least they can do is you can recommend is to use mouthwash with fluoride, or brush their teeth at the gum line. Just simple things that can actually avoid things early on. Here is another caused by medication. This woman in a facility, she takes a couple medications before she sleeps. She has sleep apnea. She has behavioral management. So she gets a couple of those medications that just are sedative. She gets up in the middle of the night. She is also in assisted living, so she doesn't have a carer staying with her all the time. She gets up to go to the bathroom. She falls. We don't know what time she got up, how she felt, what she hit. She was found on the floor by the nurse about 5:30, 6 o'clock in the morning, because I got the call 8:30 in the morning. And when I went in, of course, they saw the bruising and all that. This picture I took later, as you can see, the pictures were, the bruising were kind of fading, but she was still uncomfortable. So when I went in again, I was allowed, I mean, she let me. She was at the same day, she was so in pain, she didn't want to see anyone. And then I saw the teeth. The tooth was actually moved out of the way. She couldn't bite, she couldn't eat. Every time anything touched that tooth, she would hit people. She was just miserable and in pain. And of course, she couldn't say what is wrong, but nobody, the family caregivers would see just her unfriendly behavior, that she was yelling, screaming, cursing, and anybody came near her face, she would just basically hit them. But it's very important for us to see why their behavior suddenly changed to that extreme. And pain usually is a good cause, good reason, I must say. As far as mentation, what I want to say, and it's very true, the more cognitive decline we have in individuals, the more poor oral hygiene they have. The reason for that is they require more help for keeping the mouth clean, and because at that point when cognitively, like I showed you the picture, George was one of them, um, or Nancy, when they have cognitive decline, it's very hard, almost impossible for them to be able to do their own brushing, flossing, oral health that we all do on a daily basis. So it becomes even more important for patients with any kind of dementia, for any kind of chronic condition that causes dementia, to be able to focus that, to at least be able to draw some attention to the mouth, either by the family, by the caregiver, if they're in a hospital, by the nurses. There is a huge association between decline, mentation, and poor oral hygiene. So this is a good example of a 100-year-old lady whom I absolutely adored. She was 100 and she just wanted to see her 100th birthday. And she did. She had the 100th birthday. The reason I pulled this out, you can see without, I'm sure if you just look at this picture and look at her mouth, you can see this is not the most perfect mouth, but healthy, sure. She didn't have any cognitive issues, but she couldn't hear and she couldn't walk. And that's why she was in a facility. She had this little broken tooth here, which she was fine with it. She had no problem. She was eating. Her lip line was a little lower. It looked like she was a missing tooth, but there was no missing tooth. Tooth was fractured. She was fine with it. I was fine with it. But she had a little missing tooth here, and she wanted a fixed bridge. She didn't want any removable teeth. At the time when she called me in and she wanted me to do that, she was 96, so she lived with that bridge about 4 years, and she was very happy with it. She was brushing her teeth. I showed her pictures. I recommended electrical brush rather than manual brush because, as you can see, the arthritis, osteoarthritis, and on the fingers, I knew she wasn't going to be comfortable brushing teeth. And even though she's very good and healthy for 100 years old, she still is a 100-year-old woman. She had a little shake, weak hands. Electrical brush would serve her better. So that's what we did. She kept that area clean. She was fine. And we lost her to COVID 2 months after her 100th birthday. But I use this case because it was the best example for cognitive decline being associated with oral health. Versus this lady, she was in nursing home, or actually this picture we took when she was just moved in a hospice care. When they get to hospice care, I don't know why, but there is this mindset among some caregivers that that's the dead end. You don't do anything for them and you just put them there, keep them comfortable till they expire, which to a point it's true. However, I think in anybody's mouth, under any care, when there is an ulcer, a gouge, a inflamed lesion like that, it hurts. And at any mental condition or physical condition, that pain is felt. She wasn't able to express it, but she was hurting. The reason this woman was hurting so much, and I was called in because she had her hand on her mouth for a couple of days. She was just yelling, wouldn't eat, and that was it. Even for me to be able to pull her lip down to be able to do that, it took a lot of effort. It definitely took me a lot of establishing relationship in a form of trusting, touching her face. I don't know if she remembered me, but I had seen her for past few years before she ended up in hospice care. All it happened was apparently she fractured part of that's a bridge, that's not a tooth. She fractured part of that porcelain, which covered that bridge she had there. And when porcelain fractures, is actually sharper than knife. When natural tooth breaks, the enamel, the structure of a tooth may be sharp. When porcelain fractures, it's sharp. So when that fractured, basically cut into the lower lip, and that had to be long enough because, as you can see, it created this circular keratinized looking tissue, but extremely painful and inflamed. So all I had to do, I couldn't do anything else, but basically all I had to do, I was lightly with not Novocaine, but gel, numb the area, and I just went in there and polished that area. That's it. I just got the sharpness off, and she was fine until, she stayed there as long as she needed to be there. I put a telehealth there only because I do want to mention this, that having a communication or having a oral health professional on your team, on a health team, it can be beneficial because with all this teledentistry and telehealth, if somebody sent me that picture, I didn't have to go there. I would probably see this a long earlier. As soon as she stopped eating, I would say, just take pictures of inside the mouth. Let me see what's going on. Or just like, so these things can happen. The silver lining around COVID was we all overnight became very, a lot. I mean, I talk about myself. I became a lot more digital savvy than I ever was. At least I know how to take intraocular cameras, how to read them, how to transfer them, how to open up an email, open up. But these things can happen, and these things can be a lot more helpful to the elderly, especially the ones in a hospital, in facilities, homebound. They are the ones that need the most. They are suffering from this the most, and you all can help. This is another example of the fact that this lady was, her name, I guess, was Margaret. She had this big fungus infection here. I don't know if you can see right in here, you can actually see the pus a little bit also here. When I opened that crease, she hurt, and it was raw, it was cut, and it was infection there. This condition is called angular colitis. That's actually fungus infection that requires major treatment. When I walked in, the nurse, not the caregiver, was putting Vaseline on that, assuming that was a dryness. She had dry lips, which she did, but she was hurting as it was being rubbed with that whatever they were using. So and then in this case is the same issue, the same problem she has bilaterally, except she doesn't have as severe if it's not infected yet. Would it be infected? Of course. hers was infected, infected because um, she was drooling a lot. um, Parkinson patients can swallow. It affects their, I mean, you all know that better than I do, but the swallowing and becomes an issue. And the fact they constantly drool is not because they have a lot of saliva. In fact, the decrease in saliva, their mouth is dry because they can't swallow anything. Anything that the mouth, the body produces comes out. And so when the area is constantly moist with the mouth bacteria, that's how it ends up with fungus infection. So when you see the conditions, it has to be able to relate the oral impact on that. Or again, just see something unusual. Whomever is on your team that can connect to a oral health specialist, please utilize them. You serve your patients more than you know. This is actually the same person with the external angular colitis, and the reason is when I looked inside the mouth, she had a broken denture that used to be sit on 4 implants. Apparently implants got loose, lack of maintenance. When things move, they fracture. So she had, even though she at some point had teeth up there all along to be able to chew on these lower ones, when this denture broke, part of it from here and the lower denture all the way from here, even though she had this set of teeth and this set of teeth, she had no occlusion. Occlusion is when the ability to chew. So she wasn't chewing, except every time she closed her mouth, something hurt because things are out of line. And I couldn't imagine that there is no dentist needed to be able to open her mouth. This woman was on liquid diet for 2 years because she couldn't chew. And liquid diet did not, she lost so much weight. She had a lot of major malnutrition issues, and it was all related to the fact her teeth hurt and she couldn't chew. This was another man that was just accepted into a facility, I think memory care, I must say, and he had this partial denture, which probably a non-dentist couldn't see if this is a partial denture. By the fact there is this big piece of metal in front of a mouth, that's unusual, right? We can call that, okay, it needs to be examined. What happened was, even his family who brought him to the memory care didn't know he had partial. He was apparently home for a few years. The family took care of him, and then they brought him to the facility. And apparently, this partial was never taken out of a mouth. And I don't know if you know, but we always tell people that wear removable prosthesis in the mouth, we tell them you have to remove it at night. You cannot sleep. So if you have a patient, if you check and you know something is moving, they have a removable, they cannot sleep with it. They have to take it out, and it needs to be cleaned and put back in there the next day. First of all, this thing was embedded in a soft tissue. Soft tissue actually had grown over it. I had to numb him from the whole arch from there to there to be able to remove this. He was hurting. And these prongs that are supposed to be retention, I don't know if you can see, if you look closely, you can see under every single one of them, there is cavity forms. So this was in there. And this is when I removed it. I removed this thing, cleaned it. It was this lock here that opened this gate, and that was the way they removed it. It's an old style. We don't make those things anymore, but I know what it was. Right at that lock area, if you see it here, it wasn't even locking. It had a separation by basically tartar. I mean, this was a painful case. It was a very painful case. And things usually don't have to get this far if they are maintained. And during the assessment, we'll be able to address them. I just wanted everybody to see how that gate opened up. Mobility is a huge thing when it comes to preventing access. This man, there is no way he can clean his own teeth. There is just no way. This is not just arthritis. He could not even eat. He couldn't even lift that arm. But the mouth had a lot of issues. He had tons and tons and tons of cavities exposed, sitting there, and he couldn't even brush his teeth. So be able to, for this man, I actually had to put I mean, you can see both hands, how non-functional they are. All I had to tell to his caregiver to not use toothpaste. Do not use toothpaste. Toothpaste is hard to clean out of their mouth. It's hard to rinse. It's hard to swish around for people that don't have the muscle strength to be able to do that. And that foamy thing, they just fight it. It's not comfortable. They don't want to do it. Just dip the toothbrush in a mouthwash with fluoride. Any kind of mouthwash, any kind of fluoridated mouthwash, doesn't have to be a special brand, but to be able to brush their teeth with just a mouthwash, they don't have to rinse. It won't make him sick. They don't swallow anything. Just clean it, and that's it. That will do a lot of prevention work as they don't have access or financial ability or anything to go to dentist, or most facilities don't have dentists to come in. So prevention, you play a big role there. Is everything that doesn't look good diseased? No. This man could chew steaks on his whatever is left of the teeth. No infections, no mobility, no gum disease. All the teeth, as you can see, the roots are necrotic, natural, we call it natural root canal, no pain. He's eating. Those roots do not need to come out. We don't have to make him dentures. It's just, let's see if he's functional and has no pain. And that's all there is to it. They should be functional and have no pain. And as long as that's what they have, nothing needs to be done. But when they do have loss of function and they have pain and it's impacting their nutrition and everything else, we need to see that. Removable prostheses need to get cleaned. I mean, I keep putting that picture up because it was something I had never seen before. Just to be able to keep things clean, it keeps patients, individuals functional and pain-free. When they are not cleaned properly, when they are not removed properly, they do cause infections. They do cause a lot of problems. They do cause lesions. And the sad part is, as you all know, people that have other health conditions, they don't heal fast. The wound healing is a problem. So for someone with this kind of pain to be treated for 2 weeks, sometimes 3 weeks, to be able to not have the pain anymore, so they can actually consume, be able to eat again, That's a long 2-3 weeks for somebody who's in pain in the mouth. Herpes zoster can, the case that happens in the mouth are very, very painful, very painful. And they can be prevented basically with proper oral hygiene. If they are not, if the partial dentures are not fitted properly, if they're loose or they sleep with them at night, as impossible that it can be, they can swallow it. It gets stuck. It can be can actually cause a lot of problems. Actually, this person was, this picture was given to me by a ER physician. And then we have, again, when I showed that first picture, look under the gum, under the tongue, look into the cheeks, because you never know where the early oral lesion is, oral cancer lesion is. Oral cancers are 8% of all cancers and have the highest rate of mortality. The treatments are usually late stage, very invasive. After treatment, they may live 3 to 5 years, but the quality of life very low because it's very invasive to treat a late stage oral cancer, and they are very rarely are diagnosed on an early stage. And this case happened to be renal cell carcinoma. And at some point, it probably was just a little redness in the back of it, behind the teeth, closer to under the gum. So looking at in the mouth, just looking in the mouth with no expectation, no diagnosis, don't be afraid. Anything doesn't look good, note it. Again, as I said, the teeth do not have to be pretty to be healthy. And that's the most important thing. So here we come to the very, the meat of a presentation, I must say. The 4Ms has two workflow. We have the hospital flow and we have the primary care flow. And in both of these flows, age-friendly health system starts with intake into the care setting. And that's where you start to put them in the system. And I think that's where exactly oral health belongs. Look in the mouth. As simple as that. Ask a couple questions. Do you have to take your teeth out? Anything removable? Anything hurts? When was your last checkup? Just a couple very generic questions right in the beginning, kind of get a tongue depressor and look around. That's all it takes. It's just assessment, making a note. That's how individuals come in, and that's how you actually and clinically introduce oral health into the 4Ms. Here is our second. I figured after everything I told you, now I want to know, do you think oral health is missing in age-friendly health system and in our professional education? That's a good question. It's a fair question. So respond to that, please. So I don't know if I talked about everything that I wanted to talk about, but I think it was a great introduction. Just, hey, mouth is part of oral health. I mean, part of overall health. And a happy elderly is a healthy elderly and pain-free elderly. I probably don't have time with all the questions you may have, but please, this is my email. It's my name. mariam.tabrizi@uttmc.edu. So feel free to email me, ask questions. I promise I will respond to you. Maybe if not the same day, I will. If you send me pictures, you want to ask question on some specific case, I'll be more than happy. We here at UT, we have monthly tele echo sessions. If you go to our website, I'll be more than happy to have you on a team. If you come in with questions, with cases, that's all it's about. Tele-echo is what group of healthcare professionals come together from all across discipline, not just dentists, all across discipline. And we look at everything in one individual and we see what works best. So here we are, and towards the end, I hope I was able to give you a few tips that you may want to know, and just tell you that oral health is part of overall health, and it is part of a 4Ms, and it needs to be part, and it is not that needs to be, it is part of age-friendly health system. With that, thank you very much for your time, and hope I have more chance to talk to you later. Bye-bye.